Alright, this is Stephanie Huff, and I am documenting a recording for inflammation, and this will be on appendicitis. So an overview, appendicitis is basically just an inflammation of the vermiform appendix, and I've got you a picture here just showing you the location of the appendix. It is a common cause of acute abdominal pain. It can occur at any age, but is more common in your adolescents and young adults. It does affect over 5% of the population. Most of your treatment is going to involve emergency abdominal surgery. The appendix is a tube-like pouch that is attached to the cecum, located just below the right ileocecal valve. This is found in the right iliac region, also known as McBurney point. There's a slide that has a picture that shows the location of the McBurney point. Obstruction of the proximal lumen of the appendix is apparent in most acutely inflamed appendix. The appendix can swell and become more infected and may actually rupture. It's also known as perforation. Etiology: it is caused by an obstruction of the fecal lift, which is a hard mass of feces. Risk factors: your adolescent males are going to be at greatest risk. Diets low in fiber or high in carbohydrates are also a risk factor. Gastrointestinal infections can actually promote appendicitis as well. So prevention, obviously there's nothing that can be done to prevent appendicitis. Certain dietary habits may reduce the risk, such as eating foods with high fiber content. That's going to be your fresh fruits and vegetables. Your clinical manifestations: it's usually a continuous mild upper abdominal pain. It's more generalized. Sometimes they just kind of have generalized abdominal pain. Probably most often you usually see pain around the umbilicus at first, that then localizes to that right lower quadrant. You remember that's known as McBurney's point. Usually they'll have a low-grade fever. This pain is aggravated by moving, walking, and coughing. It's basically anything that disturbs or jars the appendix causes them to have pain. You also see rebound tenderness on palpation, and that's basically when you push in on their stomach over McBurney's point, and then you release it pretty quickly, and they have more pain when you let go than when they push in, and that's known as a positive rebound tenderness. Your elderly often have less acute pain and localized tenderness, so diagnosis is often delayed. Complications can also develop sooner in your elderly, and this results in an increased mortality. Pregnant women can also develop appendicitis due to possible displacement of the appendix by the distended uterus. Your complications: perforation is manifested by increased pain and high fever, and that is when the appendix does actually rupture. That can lead to small localized abscess or even a localized peritonitis or significant generalized peritonitis. Your peritonitis signs and symptoms: they will have a hard, rigid abdomen. It will be hard and like a table or a rock, so it'll be very rigid. This can be life-threatening. Abscess is just an accumulation of pus. Chronic appendicitis is chronic abdominal pain with recurrent acute attacks at different intervals over several months or more. Some of your other lifespan and cultural considerations: it is uncommon for children under the age of 4 to develop appendicitis. Appendicitis in young children often progresses to a rupture because they can't accurately tell their parents how they feel or where it hurts. These symptoms of listlessness, inconsolability, vomiting, and distended abdomen are common symptoms found in infants, but because it's rare for them to have appendicitis, often when they are seen for these symptoms, appendicitis is not forefront on the physician's mind, and it's not usually a part of the differential diagnosis. Alright, so looking at the other end of the spectrum, less than 30% of older adults will present with the classic symptoms. Almost half of them are afebrile. Half of them have no rebound tenderness or involuntary guarding. and 1/4 have no right lower quadrant tenderness or pain. They're more likely to present with confusion. Approximately 25 to 30% of older adults with appendicitis don't seek treatment until 3 days or more after the onset of symptoms, and that's one reason why a lot of times they have complications. Collaboration for an acutely inflamed appendix can perforate within 24 hours, so rapid diagnosis and treatment is going to be important. Looking at your diagnostic test, your book talks about abdominal ultrasound being the most effective way to diagnose acute appendicitis. It is often very useful in patients that have atypical symptoms like your older adults. A lot of times these diagnostic tests are not only done to confirm a diagnosis of appendicitis but also to rule out other causes. So a lot of times your x-rays, your intravenous pyelogram, urinalysis, and pelvic exam are done more to rule out other causes. Your white blood cell with differential is done to kind of help confirm your diagnosis. You will have an increase in the white blood cells with appendicitis. A lot of times we'll just use a CT of the abdomen and pelvis with contrast to determine appendicitis. They can also rule out other causes, and it's a little bit more invasive than an ultrasound, so it shows a lot more detail of your structures and organs in the abdomen and pelvis. They are given oral contrast to drink, but they are still able to have surgery even after drinking oral contrast. That does not affect them having surgery and does not delay their surgery. A lot of times food and other things that they've had to drink may delay a surgical procedure. Your pharmacologic therapy, IV fluids are given prior to surgery to restore or maintain vascular volume and also to prevent any electrolyte imbalances. Antibiotic therapy with third generation cephalosporins is done. Some examples of these third generation cephalosporins: cefoxitin, ceftriaxone, cefazidine. These are initiated prior to surgery. They will give them another dose during surgery, and again they will repeat it after surgery for usually at least 24 hours after the surgery. It may be longer for someone that's had a ruptured appendix. If you have a patient that has a sudden disappearance of their pain before they go to surgery, that usually indicates that their appendix has perforated or ruptured, and that's another reason why we hold those strong analgesics until the diagnosis has been confirmed. Alright, so surgery, treatment of choice is going to be an appendectomy, just a removal of the appendix. There's two different routes they can do. Laparoscopic approach is insertion of an endoscope that will actually view the abdominal contents. They will make several small incisions. Has several advantages. One is they will have direct visualization of the appendix without having to do the laparotomy. Second is post-op hospitalization is a lot shorter with this approach. Third is post-op complications are more infrequent. And the fourth is recovery and return to normal activities is usually pretty rapid with the laparoscopic approach. Your laparotomy is a surgical opening of the abdomen. It's also known as an open appendectomy. They will make an incision over McBurney's point, and this is usually done if the appendix is ruptured so that they can get good irrigation of the peritoneal cavity and try to prevent that peritonitis from occurring. Nursing process. Some of your nursing management is going to include that collaborative assessment, including the surgeon providing pre- and post-operative care, preventing complications. On your assessment, looking at their health history, you want to get current manifestations of their symptoms, including the onset, duration, progression, any aggravating or relieving factors, the most recent food or fluid intake. So a lot of times you'll ask them what they ate, how much they ate, and what time they ate. And this is going to also include fluid intake, even water. You want to know any known allergies and current medications that they're on. Some medications may actually delay their surgery. You also want to know any history of chronic diseases that they may already have. Physical examination is going to include vital signs. You also want to include the temperature in that, their apparent general health. Their abdominal assessment should include shape and contour of the abdomen, their bowel sounds, any tenderness to light palpation, and the location of that tenderness. Diagnosis, these are your NATA diagnoses for nursing. You've got your impaired gas exchange, risk for fluid volume deficit, risk for infection, acute pain, anxiety, and fear. In planning care, you want to develop collaboration with the client and the family. The client should be able to articulate concerns about the surgery and understanding of the procedure, the reasons for the surgery, any preoperative instructions that may be included. The client should be able to verbalize relief from pain with medications that they are given. Clients should receive appropriate postoperative wound care, and the client should verbalize instructions for self-care prior to being discharged from the hospital. So when we're doing implementation, when we're promoting the effective respiratory gas exchange, it is important for the client to turn, cough, and deep breathe. This will help prevent atelectasis from occurring. You want to encourage ambulation as soon as possible after surgery. For uncomplicated appendicitis, usually they're willing to get up right away. For your clients that have had a ruptured appendix, they're usually a little bit more hesitant about getting up and moving around so soon. But your goal is to get them up walking around about 2 to 3 times a day, and this will help decrease their recovery time and also reduces the risk for development of pulmonary complications. Your client should be encouraged to splint the incision with a pillow during coughing, and that will help alleviate some of the pain from coughing if they can splint that incision. Incentive spirometry is given after surgeries, and that's kind of helps with the same thing as the coughing and deep breathing exercises. Young children, a lot of times they may be resistant to it using that incentive spirometry, or they just may be too young to even understand the whole concept. So alternatives, you can make sure you have a thing of bubbles. They can blow bubbles. You can get pinwheels and let them blow on the pinwheel and make it spin. Blow cotton balls across a table, and this gets their lungs working the same way as the incentive spirometry would. You also want to give praise. A lot of times you can give them stickers when they have done it and done these appropriately. This will help to increase their compliance, so then they'll want to do these activities because they know they're going to get another sticker out of it. All right, promoting fluid volume balance. You want to monitor and continue the IV infusions that were started preoperatively until the bowel sounds and function returns after surgery. Once the bowel sounds return, and if they've had an NG tube and it's been removed, you can offer small sips of water. If they tolerate that, then you can add other types of clear fluids. You want to monitor them from nausea. Also monitor their intake and output. A lot of times if they've had a ruptured appendix, they're going to have an NG tube that's hooked up to low intermittent suction. And so you want to make sure that you're including the output in your INO as well. In preventing infection, again, monitoring vital signs, including the temperature, tachycardia, and rapid, shallow respirations can indicate a ruptured or perforated appendix. That usually leads to peritonitis. They may also have a fever as well. If their blood pressure decreases, that could indicate that they have become septic. You want to maintain that IV infusion until oil intake is adequate. They also use that IV to administer antibiotics. You want to assess the wound, also looking at abdominal girth and their postoperative pain. If you have swelling in the wound, an increased abdominal girth, or increased pain, that could indicate infection or peritonitis. In promoting effective pain management, you want to assess their pain, the etiology of the pain, location, severity, and duration of the pain. Administer analgesics as ordered preoperatively and postoperatively, and remember, they do not give the strong analgesics preoperatively until after the diagnosis is made, because you don't want to mask their symptoms. Assess effectiveness of the pain medication. This is done 30 minutes after administration. Any unrelieved pain needs to be reported to the physician. This could indicate a complication or even excessive gas. A lot of times with the laparoscopic, they do put a lot of gas in the peritoneal cavity so that they can better visualize organs and make sure that they're not nicking organs that are in close proximity to the appendix. So it takes a bit for that gas to be reabsorbed by the body and expelled. All right, promoting psychosocial well-being. You want to make sure that you're preparing your client for surgery, providing emotional support for not only the client but the family as well, making sure that they have good comprehensive education. This will help reduce their anxiety. The more information you can provide for them about what's going to happen, what to expect, and what to expect postoperatively, this will help decrease their anxiety. You also want to encourage them to ask questions and answer any questions that they may have. And providing effective client teaching. You want to give instructions on reestablishing their diet slowly and as tolerated. And they need to be able to recognize manifestations that need treatment, like infection. All right, so if the ruptured appendix... All right, so if they've had a ruptured appendix, the client will have several days in the hospital so that they can get IV antibiotics. Family and the patient need to verbalize how to do wound care. They also need to know the signs and symptoms of a wound infection, when and how to take their temperature, any activity limitations and restrictions when they need to be returning to work and school. Also looking at pain management, that will include the medications that they're getting, instructions for those, possible side effects of those. All right, looking at evaluation, the client should be able to demonstrate effective respiratory gas exchange. This is evidenced by normal breath sounds, oxygen saturation greater than 95%. They have not developed atelectasis. Client will not develop a secondary infection. Client's pain should be able to be managed effectively. The client and the family should be able to verbalize understanding of the condition. Adequate hydration needs to be achieved and maintained, as evidenced by a balance in their intake and output. No signs of fluid overload or dehydration. Client should be able to experience decreased fear and anxiety associated with hospitalization and the procedures. All right, so that is the end of appendicitis. And again, as always, if you have any questions or need clarification, please let me know so I can clarify things for you.